for Wednesday virtual morning report. It's good to be here. A rare treat to be here for me and Steph these days. We've gotten very busy, and Steph won't be with us, but really excited to learn with y'all and hear about a case. And while people are still trickling in, I'll just share something cool that I was watching the VMR from yesterday with Aaron. And it's very cool, by the way, that he's in San Francisco now. But it was a case of diplopia, and they were discussing about how double vision is a problem with eye misalignment, sort of disconjugate gaze, essentially. And Aaron suggested sort of for people to experience this themselves if they want by essentially like pressing on their eyeball. So I was like, okay, let me try that. And I looked out the window and I, sort of staring at a car, and then I kind of pushed, on my eyeball like this, and I saw the car like go like this, turn into two and come back every time I would push. And I got really excited. I even like recorded a video and posted on Twitter about it. And then suddenly I realized that for anybody who can cross their eyes, you can achieve the exact same effect without having to like manipulate your eyeball, which kind of hurts and is uncomfortable. So I deleted the tweet. Anyway, so if you can cross your eyeballs, you cross your eyes, try it, stare at something and see how it turns into two. And it's very different from blurry vision, right? It's actual like double vision. And if you're not good at crossing your eyes, then you can definitely achieve the same thing by pushing on your eyeball. Anyway, that's what I learned from yesterday's VMR. It was fun. So does anybody, other than Raphael has a backup case, but does anybody have a case they are excited to present because it's a fun case, or that doesn't have a diagnosis and they want to crowdsource a diagnosis, which, by the way, is something that I think we could all do more often. And then if anybody is interested in discussing, please come forward. We have a very nice, intimate gathering today. Well, given Marilena had also offered to discuss if needed, so we can go with that. But given that we're a close small group, we'll be able to all talk in a chat, and then certainly if it's a more complex question or thought that is hard to type out, unmute anytime and share with us. Shall we, Raphael?
Sure. Just wait for the whiteboard to be shared.
Madalena, can I hear you say your name?
Yeah, so my full name is Madalena, but I also go by Maddie, and I equally like both names, so you can call me Maddie or Madalena.
Okay, thank you. Madalena. Okay, that was helpful to hear.
Yeah.
So we'll start with the chief concern, which is chest pain in a 48-year-old male for 1 day.
All right, so chest pain in a 48-year-old male for 1 day. So when I first think of chest pain, the first thing that goes through my mind is that I need to rule out life-threatening and emergent causes immediately, or at least, consider them before going to the non-emergent causes. And CB Silvers has a really helpful 4+2+2 mnemonic for those, which are the 4 cardiac, the 2 pulmonary, and the 2 esophageal life-threatening causes. So we can go through those. And in a prior discussion, I think it was Robbie who had mentioned, what would make you always want to rule out those life-threatening causes, but is there any other symptom that would make you lean into those even more? And that's the presence of dyspnea. So if there's also shortness of breath in addition to this chest pain, that I think you would be even more concerned of the life-threatening causes. So just to go through those, so the 4 cardiac causes, that's acute coronary syndrome, aortic dissection, tamponade, and then Takotsubo. I have a hard time pronouncing that. And then the 2 pulmonary is the pulmonary embolism and a pneumothorax. And then the 2 esophageal are esophageal rupture and esophageal impaction. So those are kind of the 4 do not miss causes. And I think we have the time course here, which is 1 day. So I would put that in the acute bucket. And that's, making me even more concerned for a highly morbid kind of do not miss cause, given that it's acute. So, in addition to getting more information about the history, I think we definitely know that this person will probably have an EKG, a chest X-ray, and some basic labs in their workup. But I would want to know more information about associated symptoms. Is the chest pain radiating to a certain location? Is there associated shortness of breath? Is there leg swelling? Is there is the chest pain worse when they lie down? And if they've had this type of pain before. So that's what's going through my mind.
Beautiful masterclass. Chest pain is such a common symptom, and obviously a scary symptom. I'm sure almost all of us have had some experience with it in our own kind of pearls and approaches and stuff. Does anybody else want to share anything else they feel like they wish they'd learned earlier about approaching chest pain, or that they learned recently and think is really good? What other pearls do people have about sort of an approach to chest pain?
A pearl that I really enjoyed, that I learned with Rabbi, is to make sure you look at the skin of the patient, because you could be dealing with zoster,
That's awesome. I've been burned by zoster a couple of times like that. Burned of just doing a crazy workup, and then 2 weeks later the rash appears, and it's like, oh, it's tricky in that way, because if the rash was there, it would be easy, but the majority of the time the sensory symptom precedes the rash, right? And it can happen literally anywhere. Same we're saying, GERD esophageal kind of spasm or pain can definitely sound a lot like what we think of as anginal pain. And
yeah, Nikita also, oh yeah, go ahead. I was just saying, Nikita put a really great thought about, are there any triggers like strenuous exercise or alcohol? And I think that kind of relates to like Anne-Marie's, your comment about like a natural stress test. Like, does it get worse with exertion? I think that's really helpful.
I love it. I'll, and we could talk for a long time, but I'll just share like 3 of sort of my most common I guess additions whenever I'm evaluating a patient with chest pain with learners. One is to stress that history is important always, but I think especially with chest pain, it's so much about the history in terms of how you're going to think about the patient. And importantly, even though like we are trained to like think of those really life-threatening immediate things, and our brain is going to like want to like chase after those right away, it's as important as ever to really like ask the patient, and allow the patient to just like tell you the story from the beginning, to Nikita's point, right? If you don't get into the specific questions too early about whether it's radiating or pleuritic or all those things, and just be like, all right, tell me everything, tell me the whole story, how did this start, what's been going on? And if the patient starts with like, okay, so 2 days ago I did an upper body workout, right? Suddenly it's it's a lot, it's very different, right? Or if you it can be any number of things, right? Like, okay, so my it's been a really hard week in general. My mom was in the hospital, had a massive heart attack 6 days ago. I haven't been sleeping or whatever, right? So I think that's one thing to and even in cases where it's like, is this like, should we cat this person? Should we stress this person, right? If you think about like when you're attending comms, or then when you consult the cardiology and a cardiology resident or fellow comes, and then the cardiology resident comes, right? Every time they're like, so tell me about this pain, right? And it's really so much about like the characteristics, the description of what was experienced in determining whether this is potentially, sort of ischemic or not. Okay, that's a good segue into pearl number 2. Our job is not to rule out ACS, right? Our job is to diagnose chest pain. So frequently we do focus so much on the most common of the life-threatening causes, right? That oftentimes when like the discussion is purely binary, like is this a coronary event or is this not? That we often kind of don't spend enough time thinking about the rest of the differential diagnosis, which together is the strong majority of people. And I suspect most of y'all have seen those patients where like, we sort of like finish the workup and are ready to discharge them, but it's like, wait, what's actually causing their chest pain? And we don't know and haven't necessarily told the patient, like and it's fine if we don't know necessarily, right? Like there's not clarity, but at least telling them what it's not, telling them what it could be, maybe reassuring them that it'll probably go away on its own, et cetera. Okay, so I think y'all are generally all over that too, given the differential you listed and some of the great pearls. My last one is gonna be to really try to like realize when it's not even like chest pain. So when you hear chest pain, immediately your mind is like in that schema, right? But realize when it's actually thoracic pain. When it's so very clearly chest wall pain, right? Because I promise you, it'll still get labeled as chest pain by the ED and you'll be sending troponins and EKGs and whatever, right? But if the patient is just like, it hurts right here, right? Which very often they will point with, it hurts, it's like hurts right here, right? That's not chest pain. Like aortic dissection isn't in the differential for that, right? That's thoracic pain. Maybe I guess it could be pleural pain, but it's just a different thing. And you're in a different schema, different mindset, and you're zooming into the layers of the chest wall, right? From pleura to skin, as opposed to thinking about like the viscera and all that.
I love that. Those are just such great pearls, especially kind of the mimickers. Like, is it not chest pain? It's actually, just thoracic pain. Because I think I notice in myself, chest pain, it's like, oh, 4 + 2 + 2. Like, want to make sure it's not one of those. But I think taking a step back and really thinking, is this actually chest pain, or is it someone just describing it as chest pain? But it's really, maybe we need to consider the whole thorax. That's such a great pearl. Shall we get more information, Rafa?
Sure. Just want to add on that thought that Marilyn just shared with us. I also had an attending and I was like, oh my God, is this myocardial infarction, like the chest pain? And she was like, oh, is the pain reproducible? I was like, what? What do you mean by that? And she was like, try to do this with the patient. And when I did this, the patient was like, oh, it hurts. So we were like, oh, no, don't worry, it's probably a costochondritis, like I was like, and I was so worried because of myocardial infarction. And it seems like when you have myocardial infarction, it's not reproducible, right? Like it's a constant pain. So I really liked that when she taught me that. So moving on, this pain is sharp, substernal, and non-radiating, and neither alleviated nor worsened by position, activity, or respiration. Past medical history of this patient has end-stage renal disease, hypertension, anemia, and gout. Medications include aspirin, carvedilol, colchicine, and sevelamer. When it comes to the reveal of systems, this patient denies weight changes, fevers, chills, and night sweats. This patient also denies headache, blurry vision, blurry or double vision. He endorses chest pain and palpitations. He also denies shortness of breath, cough, hemoptysis. And when it comes to the neuro, he denies lightheadedness, and dizziness. And that's the end of the aliquot.
All right. So in this aliquot, we have a little bit more information actually we got more information on the background kind of and the foreground. And I think really what I'm trying to do here is, does the additional information that we got make us more or less concerned about kind of those do not miss causes? And, I think to the point that was brought up is, is this actual chest pain or is this more in the thorax? I think the fact that it's sharp and substernal makes me more, I guess, confident that this is more like true chest pain. But I'm maybe saying that with a little bit of hesitation. Let's see here. So endorses chest pain and palpitations. So I'm concerned with the palpitations. I'm concerned, is there some kind of arrhythmia here? Or is the problem localized to the heart? I think that's what I'm concerned about. However, it's interesting, like usually if you had palpitations, maybe like that would, impair the perfusion to the brain. So I would expect the person to be somewhat lightheaded, which is not what we're seeing. I'd also expect that person to be dizzy if they were having, some kind of arrhythmias. So that's kind of is making me pause. In terms of the past medical history, this person is a 48-year-old male. He has a lot of risk factors for, I'm hesitating because I know you're saying our job is not to like rule out ACS, but I'm seeing some risk factors, just like the hypertension and hypertension mainly, for example. I'm also interested in the anemia. I'm wondering, is that a chronic thing? Kind of like, what is the cause of anemia? Because anemia is not just kind of one diagnosis, there's, causes of that. So that just kind of stood out to me as something that I would want to know a little bit more about. Like when was he diagnosed with that? Was there a workup done in some way? So, going forward, I would want to know, what would I want to know? Of course, like the vitals, I want to make sure, is this person stable? So, are they hypotensive, hypertensive? So vitals is especially important. I think for the exam, we talked about this in the last aliquot, but, seeing if this is pathology primarily of the heart, you want to see, is there any jugular venous distension? Is there any swelling of the legs? I know that there's no shortness of breath or cough, but you want to see, is there any kind of crackles in the lungs? So those are the things I'd be looking out for. But yeah, takeaway in the past medical history, I'm seeing some signs that could increase kind of the cardiovascular risk, as Seamus said in the chat. But really I'll be interested in the vitals to see how stable this person is and how quickly we need to intervene. Zavin, I'm curious kind of what this additional information did to you in terms of what you're more concerned about.
Yeah, so I think I was thinking a lot of the same things as you in response to both the background and the foreground, and you described all of them well, so I won't sort of reproduce, of course. And I do think, I didn't mean to say that our job isn't to rule out ACS. Our job is not only to rule out ACS, right? I think anytime there's chest pain, we have to rule out MI or think about ACS. But if that doesn't seem to be the case, I think my point was our job isn't done, right? So I think in this case, you're absolutely right to point out that not only the hypertension, but anyone with ESRD in middle age is at very high risk for atherosclerotic vascular disease. Mm-hmm. By the time that you have ESRD, you've progressed, unless you just had a bilateral nephrectomy, right? you've progressed over years through various stages of CKD, which by definition come with, hypertension, metabolic derangements that cause endothelial damage, and, sort of procalcifying pathophysiology. So anybody with this background, is very high risk for heart attack, strokes, peripheral vascular disease, and the rest. So I think that was very astute, and we absolutely have to worry about that. In addition, Anne-Marie made an excellent point that the tenderness of the chest could be helpful, but it's actually not as good as you think. If the chest is tender, you would think what kind, it doesn't make sense with anginal pain, but the negative likelihood ratio isn't it's not 0.1. Okay, it doesn't decrease the probability to 0, because pain is experienced a lot of different ways, but so it's not a perfect test. And I would just sort of commentate there a little bit that it depends on how tender you are, right? If you do this and you're yeah, that makes it worse, right? That's one thing from doing this and the patient jumping and be wait, is that the pain you've been experiencing? Be yeah. Ooh, please don't do that again, right? So there's a spectrum of everything, and I think that goes for various bedside tests that we do too. Things aren't just positive or negative, right? It could be very positive or very negative, and I think that it's logical that it would be there's a difference. So with all that being said, I think the description is something that could be within sort of the range of atypical presentations of coronary insufficiency. I think the thought about pericarditis is great. We didn't get the positionality, and we didn't get sort of a pleuritic component with deep breaths, but those aren't perfect either. I will also just say the word sharp as a descriptor also isn't perfect. A lot of people, especially if you're the one who asked, is the pain, what's the pain like? Is it a sharp or dull, right? A lot of times people will say sharp when they really just mean strong or severe, for the pain. Yeah, I think that the historical information that would be most helpful to me at this point is actually a little bit more detail about acuity of onset, as well as what the kind of subsequent time course was, how the discomfort in the chest coincided with the palpitations or not, as well as whether the patient still has the discomfort, right, to the moment that you're taking the history. Why is each of those things important? So anybody who spent time with clinical problem solvers knows that time course is the most important thing, right? And it's certainly acute versus chronic, totally different differential, right? But getting even more granular with the time course, even within acute, if something starts right over a 15-minute time period and crescendos, as opposed to something starting all of a sudden in a second, hyper acute onset, for example, even if it's been since then going on for 2 days, whether it started hyper acutely or a little bit more insidiously, kind of might prioritize certain types of pathogenesis over others. So for example, an aortic dissection, classically, if you hear somebody was just sitting there and suddenly they felt a very sudden onset of pain, especially if they describe it as ripping or tearing or radiating to the back. If you have all three of those characteristics, very sudden onset, ripping or tearing, radiating to the back, that has a very high positive likelihood ratio for aortic dissection. Just one example. Okay, what happens subsequently? How does that help? One way in which that helps is the whole, the palpitations invoke a possible arrhythmia, right? And the arrhythmia could be causing chest discomfort by creating demand ischemia, for example, right? So if subsequently, the pain starts and then suddenly it goes away and I didn't do anything and the palpitations went away too, and then an hour later it comes back again with the palpitations, it seems like kind of might support potentially kind of a arrhythmia being causative of the pain. The limiting factor there, the complexity, is that sometimes people, the palpitations could just be either sinus tachycardia or an increased kind of hypersympathetic state with like a stronger squeeze, making you more aware of your heartbeat, and it doesn't necessarily mean an abnormal rhythm. And then finally, kind of segueing into the last thing I said, which is the pain still present now? If it is, it's a lot easier for you to correlate that with the vital signs, right? So if I'm having that same discomfort right now sitting in front of you, and I'm having some palpitations, but my heart rate is 80 in sinus, then it's not the heart rate, right? And the palpitations are like a secondary phenomenon. They don't represent an arrhythmia that could be causing this pain. And if the patient's still experiencing the pain in front of you, it actually gives you an opportunity to sort of like characterize it better. So for example, anybody who is saying, yeah, I'm still having that chest pain, instead of just saying like, oh, does the chest pain get worse with breathing? I will actually ask them, I'll say like, take a deep breath with me, just, and watch them do that. And I think you're much more sure that there's a pleuritic component if they're like, oh yeah, that doesn't feel, or you like see them catch and stop their breath halfway because clearly it sharply exacerbated the discomfort. Other than that, I think, as you said, Madalena, I think there's still a lot of kind of diagnostic uncertainty in both the vitals exam as opposed to as well as the main core tests that we just absolutely cannot do without in a patient with chest pain: the troponin, the chest X-ray, and the EKG. We have to have them to go further.
Incredible discussion, everyone. So moving on with the physical exam, vitals. His temperature is 99.1 Fahrenheit, heart rate 141, blood pressure 84/58, respiratory rate 14, and he's saturating 96% on room air. Generally speaking, this patient is in mild distress. Cardio exam: tachycardic, regular, distant heart sounds, normal S1, S2, and no murmurs. When it comes to the lungs, diminished breath sounds, no wheezes, rales, or rhonchi, and there is no edema. I'm also going to give you the initial labs. CPK for this patient was 37. The CPK, the 37. The troponin was less than 0.1. The dimer 2,985. And CBC and metabolic panel unchanged from patient's previous baseline labs. And that's the end of the aliquot.
All right. So the takeaway from at least the vitals, but everything else, is that I'm very worried about this patient. So what stood out to me from the vitals is that he is tachycardic and pretty hypotensive, especially when you got the past medical history that he's a history of hypertension. So I think just the contrast makes it like is even bigger. And you could even think about the buckets of shock in this case, but I mean, I think from the rest of the physical exam, I'm concerned that this is a cardiac etiology. So I think the distant heart sounds, I think they mentioned it in the chat, but I'm worried about tamponade because that would be consistent with distant heart sounds and also diminished breath sounds. And that would also explain the tachycardia. So I think from the physical exam, that could be an exam consistent with cardiac tamponade. I'm trying to think like for the exam, there's no mention of, there's no mention of that. So I think in tamponade, you would also expect an elevated JVD, but I guess there's no mention of that in the description. the D dimer, I'm trying to see if the labs would be consistent with this current kind of prediction of cardiac tamponade. And I'm not sure what you would expect the D dimer to be in cardiac tamponade. That's something that's just a question for me. I see the D dimer is elevated. And I'm not entirely sure what to do with that, frankly. But what would I do here? So I think the takeaway is the exam makes me concerned for something like cardiac tamponade. I'm not entirely sure how the normal troponin and elevated D dimer fits into that. But to further evaluate the tamponade, you could even do like point of care ultrasound. You would want to get a chest X-ray. What else? I definitely still want an EKG, but I think point of care ultrasound is something I would be going to get some quick answers, as Aya said in the chat. So that's where I would go next. But Sabin, I'm curious what does the elevated D dimer and normal troponin do for you?
So the normal troponin is obviously very helpful, right? If the onset of this pain was many hours ago, and the troponin is, especially some of the newer assays, especially if it's high sensitivity, if it's negative, there's not like a significant occlusive coronary event that has taken place, especially in somebody with ESRD, because a little bit of troponin leak goes a lot further in a patient with ESRD in terms of clearance. And then the value, even if it's significantly elevated, like it doesn't mean there was a big infarction. So if somebody with ESRD has a troponin of 0, like very unlikely that they're having sort of a coronary event. In fact, the fact that they're tacking away at 140 with low blood pressures and aren't even having some demand ischemic injury and myocardial necrosis to leak a little troponin tells me that their coronaries are probably wide open and they don't even have like chronic coronary disease. But anywho, that's probably less important. D dimer. Pretty good sensitivity for pulmonary embolism, which by the way is very much in the differential here too. Absolutely. Right? Acute PE and a chest pain, not clearly characterized chest pain, and a tachycardia hypotension. This could be a big PE. The one thing that argues against that is if this respiratory rate was measured accurately at 14, that's actually the most sensitive vital sign abnormality in pulmonary embolism. It's not tachycardia, it's not hypoxemia, but about 80% of people with PE are tachypnic. So that argues somewhat against, but I still, wouldn't discount it if an alternate diagnosis doesn't show itself soon. A D-dimer also has a very positive, high sensitivity for aortic dissection, actually, in some series even better than for PE, which again, we weren't thinking as much in this case, but good to keep in mind. Now, I'm saying what it has a high sensitivity for, right? Meaning when it's really helpful if it's negative. If it's positive, it's actually just less helpful. I mean, if you were trying to rule out a PE with a D-dimer and it was positive, obviously it puts you, kind of keeps you on that path. But if it's positive, especially in a more kind of chronically ill patient, I would include potentially people with ESRD, it's very nonspecific and it doesn't necessarily alter my differential here that much. If you think about it, I mean, people with ESRD every couple of days, we haven't heard what kind of dialysis this person gets. And by the way, if he has, or she, or if they have missed any dialysis, which would make some things like uremic pericarditis more versus less likely, right? But anyway, if this person is getting hemodialysis, if you imagine their whole blood volume being taken out of their body, right, through a catheter, circulated through a machine and being put back in, and like their AV fistula, right, being like poked with a needle and then the needle taken out, and like there's some degree of micro clotting and clot resolution that you can imagine would lead to an elevated D-dimer. I actually don't know the data in kind of baseline D-dimers in patients with ESRD. If someone wants to look that up and teach us in a chat, that would be awesome. But the point is that I think it doesn't alter the differential too much. I think it's more all the other things that you mentioned, the tachycardia, the hypotension, that suddenly way prioritize those cardiac or pulmonary vascular causes of chest pain, pericarditis with tamponade, potentially ACS with cardiogenic shock if we didn't have the negative troponin, massive PE. I think it's those vital signs that that elevate those possibilities more so than the D-dimer for me. What other thoughts or questions do people have? I've kind of fallen behind with the chat. Y'all talk while I catch up.
One question I had is about, definitely agree that of the many things on the differential, pulmonary embolism is one that we wouldn't want to miss. And I know, I'm forgetting like how I know you can like risk stratify and that would influence your next steps. Would you get like a CT, pulmonary, like a CTPA in this case, or would you start with a point of care ultrasound? Like what would be kind of your sequential steps in this case?
So if you think about the Wells criteria, which is like one of the risk stratification scores for pulmonary embolism, to me, by far the most important thing in the Wells criteria is the one actually that gives you the most points too, which is lack of alternate diagnosis. The signs of symptoms of PE are so non-specific, right? So many things can cause chest pain or tachycardia or hypoxemia or whatever the reason was that you thought about a PE, right? So the whole question is like, is there another explanation that you feel pretty good about? And if there is, you don't need a second explanation, right? Occam's razor, and then you're done. So I think that's true in so many cases. And it's true here too, where, if the main differential diagnosis in this case is pericarditis with tamponade, then the way that we can assess that way more quickly than we can get a CTPE, right? And if we find it, we're probably done. Like, what are the chances that this person has tamponade and a PE in the same day out of the blue, right? So in this case, yeah, if I had an ultrasound probe on me, I would absolutely just look and see. If I didn't have an ultrasound probe on me, or I didn't have the skills, I would do a pulsus paradoxus, which is a manual blood pressure. Let me just share screen real quick and show you guys. So this is a YouTube video from Stanford 25. Y'all see my screen with the YouTube? Okay, so just going back to the front, they kind of go through, the pathophysiology. When you have
intrathoracic pressure will cause an increase in blood flow to the right side.
When you have, pressure in your pericardium and it can't expand, when we breathe in and more blood comes into the right side of the heart, then, normally the pericardium would expand a little bit, but in this case, it can't. So then the right side of the heart kind of pushes against the left side of the heart, and the blood pressure sort of falls because the stroke volume from the left side of the heart falls. And the way you detect that is by checking essentially a manual blood pressure cuff and listening for when, here, let me show you a different image for this part. In tamponade, essentially what your blood pressure is doing is it is varying with the respiratory cycle, right? Here, when you start breathing in, it's lower. And then when you breathe out, it's higher. And then it's lower again, and it's higher again. And when you're measuring the manual blood pressure cuff, essentially the cuff pressure is just like this dotted line coming down. And then at some point, you're going to hear intermittent cord cough sounds, right? You're only going to hear the cord coughs when it's in that higher pressure phase during exhalation. So you're going to hear dip, 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 dip. So you make note of the pressure at which you heard intermittent cord coughs. And then as you decrease the cuff pressure further, you're actually going to reach the summits of all of those little pulse pressures throughout the respiratory cycle. And you're going to hear continuous cord coughs. Dip, 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 dip. And the difference between the intermittent and continuous cord cough sounds is your pulsus paradoxus. Normally it's less than 10. And if it's, it would be probably 30, 40 in a patient like this, and that you pretty much have your diagnosis. The test characteristics of that are pretty good. So in that case, I would avert the CTPE and, call for the stat echo and call the cath lab, et cetera, et cetera. Here, Raphael, you can, or whoever was sharing the screen, or actually I'm still sharing. Let me show you guys one more thing. And it's this article that Anne-Marie might've been referring to. It's a cool series of from JAMA called Rational Clinical Exam. And they always kind of like pose the question that you would be evaluating with your history and physical, and and then they kind of summarize the evidence. So for example, all of the kind of pretest characteristics that would stratify your risk for acute coronary syndrome and how much they influence the likelihood, how the patient describes the symptoms. So for example, I don't know if y'all knew that radiation to the right arm or both arms, it actually has a higher positive predictive value, positive likelihood ratio than radiation to the left arm. And then let's see if the palpation, reproducibility with palpation is here.
I think it's the last one in that table.
Pain reproduced by palpation lowered the likelihood ratio, had a negative likelihood ratio of 0.8. So it's pretty good again, but it's not perfect, right? Okay, let's go back to the slide, and here's some more information.
So the next article is actually the EKG, but I don't have a reading. I can share the EKG. I don't know how well you'll be able to see it.
Can you hold it a little closer?
Oh my gosh, so small.
But
are there any S2 segment changes?
Actually, I can see it decently well. So, and actually the most important finding perhaps, I don't know, might be the fact that like you don't need a lot of resolution to see. I don't see electrical arts. I see kind of some respiratory variation in the amplitude of the QRS, but I don't think it's every other beat. The QRS amplitude isn't huge, right? But it's not quite, doesn't quite meet low voltage criteria, but it's borderline. Mm-hmm. It would depend on, like, if I had a baseline EKG on this patient and they had a lot more voltage, that would be helpful. So I think people in the chat are noticing that. And then what about the rhythm? Is this sinus? Is this an arrhythmia?
Are there P waves, Rafa?
No, I think it's sinus and it's regular rhythm. There are no variations between the QRS.
Okay.
Mm-hmm.
Okay, what's next?
Okay. And then it's a chest X-ray. Maybe it's easier now.
Ooh.
So enlarged cardiac silhouette. So I think this could still be supportive of our concern for cardiac tamponade.
Absolutely. It's kind of like a bulbous shape too, right? Like it looks like either the right atrium is huge or there's pericardial fluid. There were some pleural effusions too. And so I would be curious just to what the overall volume status of the patient was. There was no edema, I guess, and we don't. Okay, so what do people want next, I guess?
There's one more exam.
Okay.
To show you
one more exam.
In imaging. Yeah, it's a CT of the chest.
Okay. So it looks like what I'm seeing there is like pericardial effusion. And so pericardial effusion and tamponade physiology, which is, I believe, what we're seeing.
So you're absolutely right. That is pericardial effusion, and on a CT, it's a big one. that's something we don't, do enough, is just kind of like use all of the tests we have at our disposal, even if they weren't obtained for that particular purpose, right? We actually had a patient like 2 days ago on service for whom pericardial disease was on the differential, and we had a CT because it was obtained for like PE protocol in the ER, and they had like, we looked specifically for that, and there was 0 pericardial fluid. That doesn't exclude the diagnosis of pericarditis. A lot of times, actually, in the painful phase, it won't be effusive. So you can still very much have pericarditis, but you can't have tamponade without any pericardial effusion. Okay, what's our next test? What are people thinking?
So would you do a pericardiocentesis in this case? I don't know I'm not sure what the next step would be. Talk to cards, activate the cathode.
And Marie's saying, yeah. So I think I wouldn't, because I don't know how to, do them.
Me neither.
And I've never done one. Yeah. But I think we have one or two more tests to confirm the most suspected diagnosis based on all the information we have right now, which is, again, we need a stat kind of ultrasound of the heart. And in the meantime, again, I would check a pulsus paradoxus, and if that was elevated, I would already kind of, I would know that I'm not even like waiting for the echo in order to like get in touch with the interventional cardiologist and activate that whole process for an emergent pericardiocentesis. And yeah, so Raphael, do you want, and I would say one more thing, like, we don't have labs yet, which is okay. We don't need to kind of spend time on them, but if this person did miss dialysis and like, their sort of BUN is in the 60s or 100s or whatever, kind of representing likely some accumulation of uremic toxins. The BUN isn't itself the problem oftentimes, but it's a decent surrogate in most patients. Then it would be like, okay, this is probably uremic. By the way, extra dialysis is also very urgent, important in the treatment of uremic pericarditis. But like, if this person has just been on a normal dialysis schedule and like their BUN is like, freaking 25, or just they're not really, shouldn't be uremic, I wouldn't like forget to think about, okay, we have one diagnosis, but it's not a final diagnosis. It's not an endpoint diagnosis, right? We have to ask, pericarditis from what? And just because you have ESRD, that doesn't protect you from post-viral pericarditis. It doesn't protect you from rheumatoid arthritis. It doesn't protect you from lupus. It doesn't protect you from cancer. It doesn't protect you from anything. And in fact, you could have any of those things. Speaking of, why does this patient have ESRD? Right? We don't know yet. 48-year-old, I mean, hypertension usually itself alone doesn't lead to ESRD, diabetes maybe, but again, there's a missing piece of information that could be a whole other, kind of complexity to the case if this person has some other systemic disease that involved the kidneys and could also involve other organs. Okay, take us home, Raphael, and maybe we'll have a couple more minutes for final thoughts.
Okay, so this patient was diagnosed with pericardial tamponade. A pericardial effusion was first visualized on the chest CT, like you guys mentioned, and a subsequent bedside echo confirms the presence of a pericardial effusion and tamponade physiology, including collapse of the right atrium and right ventricle during diastole. The patient was then taken to the operating room for surgical drainage with pericardial window. The etiology of the pericardial effusion was unclear and could have been idiopathic. It also could have been secondary to uremic pericarditis, given his history of ERCG. Ultimately, a single cause was never determined.
Elizabeth, I think you're on mute, but I see your mouth moving.
Hey, sorry about that. Thank you, Raphael. Okay, closing thoughts, reflections?
Yeah, I think this was Rafa, thank you for presenting this case. This was so educational for me. I think I noticed for chest pain, for me, I sort of have these like reflex thoughts of wanting to rule out these morbid causes, which I think are definitely needed in chest pain, which can be so morbid. But I think there was, like Zamin, there was so much helpful teaching about, you know, how important the history is in chest pain in terms of the time course, like when it started, what was the preceding, and like after the initial chest pain started. I think there was a lot of learning for me in terms of the kind of how to think about chest pain beyond the doom not miss causes. And then I think, you know, Pose's paradoxis, that I think I always have to review that physiology, and the video that you showed in your explanation was so helpful. So I think this was just a fantastic case to discuss, and a lot of learning for me. So a lot of fun. Thank you.
Rafael, thank you. And Seema, I think you were taking notes, or doing teaching points, but your microphone doesn't work. Is anyone gonna summarize our teaching points?
I think Yasmin is.
Yes, Yasmin. Okay, Yasmin, go ahead.
Thank you so much for this amazing case, really educational. And now for the teaching points, we must first consider life-threatening causes. The 4+4+2 schema of CPS is very helpful. And then we also have to consider the history in patients with chest pain. How did it start? If it's pleuritic, if there are triggers such as strenuous exercise or alcohol consumption. Also, we can consider chest wall pain, just costochondritis, thoracic radiculopathy, and so on. Now, ESRD increases the risk of ACS. Actually, coronary heart disease is a significant complication of chronic kidney disease, and is the most common cause of death in this population. Now, we had increased D-dimer levels, and it has high sensitivity for deep vein thrombosis, pulmonary embolism, estimated intravascular coagulation, and aortic dissection. Now, we have to look for causes of pericarditis, not only stay with one. Remember infectious, MI, uremia, radiation, autoimmune causes. And at the end, we saw this patient had a pleural effusion forming tamponade. We must search for diastolic collapse. And to end this, is uremic pericarditis is a complication of ESRD. This is a fibrinous pericarditis that will present with chest pain worsened by inhalation. These are all the teaching points, and thank you very much for today's VMR. Back at you, Rafa.
Yasmin, that was awesome. I'm always so impressed how the teaching points ends up being like kind of richer than the discussion even, which thanks to Madalena in the chat was already so wonderful. This was a lot of fun. Thank you, everybody.
Thank you. See you guys next time.
Have a great day.